for having me in this conference. So I'm talking about macular surgery for subretinal hemorrhage. So submacular hemorrhage, SMH, is a rare complication of choroidal or retinal vascular abnormalities associated with AMD, PCV, and retinal macular aneurysm. PCV is most commonly linked to large SMH. SMH leads to photoreceptor damage due to iron toxicity. Irreversible retinal injury can occur within 24 hours. Only 11% of cases achieve BCVA better than 2200 after 2 years in old reports. So treatment options for SMH. So anti-VEGF monotherapy, pneumatic displacement with anti-VEGF, intravitreal TPA, tissue plasminogen activator, plus anti-VEGF plus PD, and paraspinal vitrectomy, PPV plus TPA injection plus pneumatic displacement. So subretinal injection of TPA without retinotomy minimizes retinal trauma. It reduces the risk of complications such as PVR and retinal detachment. This less invasive approach may lead to faster recovery and better visual outcomes. So I will present several cases of SMH. So first case is SMH caused by trauma in 52-year-old male. While playing baseball, he was struck in the left eye by a battled ball. He noticed a sudden decrease in vision. So the vision decreased to 21,000 in left eye. So we can see the SMH in the macular region. So I did PPV plus subretinal TPA injection plus pneumatic displacement. The video shows subretinal injection using 38 gauge needle. So you can observe progressive detachment. At the end, air is injected around half of the vitreous cavity. So after surgery, hemorrhage is depressed and vision improved to 20/20. So next case is a rupture of PCV in 67-year-old male. The patient noticed decreased vision in the right eye about 1 week ago. The vision decreased to hand motion in the right eye. So photograph shows extensive hemorrhage. And so OCT clearly demonstrates a significant height of SMH. So I did PPV plus subretinal injection of TPA plus pneumatic displacement. So video shows massive subretinal hemorrhage. So IN was peeled to facilitate needle penetration. So TPA was injected to make wide retinal detachment. So here. And then fluid air exchange to displace the detachment posteriorly, like this. After surgery, successfully, the SMH was displaced inferiorly, and the vision improved to 20/60. So next case is a rupture of retinal macular aneurysm in 81-year-old female. The patient noticed a sudden decrease in vision in the right eye since yesterday and was subsequently referred to our hospital. The SMH is relatively fresh, and so OCT shows outer retinal layer relatively preserved. So I did PPV plus subretinal TPA injection plus pneumatic displacement. Core vitrectomy was performed. So using magnified lens, IM was peeled, and sub-IM hemorrhage was aspirated with cutter, and then TPA was injected to make retinal detachment. So you can see retinal detachment this size. At the end, so fluid air was injected around half of the vitreous cavity. So day one, SMH was successfully displaced inferiorly, and macular condition looks good, and the vision improved to 25. So next case is also rupture of retinal macular aneurysm in 91-year-old female. The patient noticed a sudden decrease in vision in the left eye 2 days ago and was subsequently referred to our hospital. The vision decreased to 2400. So Funda's photo shows SMH as well as sub-IM hemorrhage. So this is a kind of tricky case. So SMH is not so severe, not so significant, but so we can see sub-IM hemorrhage. In such case, the possible of existing of macular hole couldn't be ruled out. So I did different surgery, PPV plus ILM peeling. Something strange. So combined cataract surgery was performed, and phacoemulsification was performed to remove lens, and then IOL was implanted. So usually I used 25 gauge constellation system. So capsulectomy was performed. So in such case, just so ILM was peeled, not removed. So carefully, so sub-ILM hemorrhage was aspirated to confirm whether the macular hole was formed or not. After confirmation of macular hole formation, so peeled ILM was repositioning. And then so fluid air exchange, kind of ILM converted inverted flap. After surgery, so SMH had resolved and successfully macular hole was closed. OCT image showed inverted ILM flap, and the vision improved to 20/50. The next case is a rupture of AMD in 68-year-old female. 2 days ago, the patient experienced a sudden decrease in vision in the left eye and was referred to us with a diagnosis of retinal detachment. So this patient came to our hospital 1 year ago. At that time, only so drusen was observed and vision was 20/20, but at this time, the vision decreased to light perception. Funda's photo shows total hemorrhagic retinal detachment, and ERG amplitude was in the left eye was flat. I did PPV plus TPA subretinal injection plus retinotomy plus removal of subretinal hemorrhage. Core vitrectomy was performed, and so SMH was coagulated. And so TPA was injected at multiple sites to dissolve the coagulated hemorrhage. So after dissolving the hemorrhage, so I cut the peripheral retina to remove the SMH completely. So perfluorocarbon liquid was injected to attach the retina. And then, so photocoagulation was applied to the retinotomy site. And finally, perfluorocarbon silicon oil exchange was performed. After surgery, so total hemorrhagic retinal detachment was reattached, and the vision improved to 2400. This is the last case of rupture of PCV in 76-year-old male. The patient had been experiencing blurred vision for a while, but had left it untreated. After visiting a local clinic, he was referred to our hospital.
Dr. IWASE, I think can we take a question now?
Oh, okay. Sorry.
Excellent presentations, videos and all. But just the very first case that you showed, where subretinal hemorrhage, there's no subhyaloid hemorrhage. It is limited to the within the arcades. That particular case maybe could have done with intravitreal TPA and gas rather than vitrectomy, subretinal TPA and gas. What is your take on that?
So, good point. So, in such case, one of the options is, so as you mentioned, so TPA injection plus pneumatic displacement is maybe so good option. But I chose subretinal injection. But I don't know so which is better for final vision. But one of the options is, as you mentioned, TPA intravitreal injection plus pneumatic displacement.
One alternative technique is to use a non-vitrectomized subretinal injection. So you just use a 41 gauge cannula and you actually mix together your TPA, anti-VEGF and a little bit of air, and you just do a single injection without the need to do the vitrectomy. So we've adopted this technique for the cases of small submacular hemorrhages. Yes, question from the floor.
Like for your question, like without doing non-vitrectomized eye, if you are giving the subretinal TPA injection, the cocktail of anti-VEGF and the air, so what will happen, like after injecting all these three cocktail injection, you have to displace the lysed blood from the fovea. Otherwise vision won't improve. That will not be possible after if you are not doing the vitrectomy completely. So you have to do the vitrectomy and do the fluid exchange at the last and finally, and inject some SF6 or C3 gas so
no.
that you can completely disperse the blood from the macular area.
No, I disagree. The purpose of the subretinal air is for the blood displacement. The beauty of putting the air subretinal as well is that the patient doesn't need to posture.
Yes, if you are giving the subretinal injection and ask the patient to
sit down,
just sit up.
The sit up position for 12 hours at least, so that by the lysed blood, due to the gravity, the RBC will go down and the air will come up, and the blood will go down, and it will be the fovea will be devoid of blood. And if you are doing the gas injection, and after 12 hours, if you are positioning it in a prone position, so the rest of the blood will go to the peripheral position, so the macula will be absolutely lack of blood. So your vision and the field of vision both will improve. And for your question, if it is less than 4 disc diameter in size, submacular hemorrhage, definitely intravitreal injections or anti-VEGF will work, especially the nodosulimab kind of strong anti-VEGFs. And for you, like when there is total retinal detachment along with subretinal hemorrhage, if it is extending towards up to the ora serrata, you have to do the retinectomy as close to the ora serrata possible. And if the duration of the hemorrhage is more than 2 weeks, you have to do the RP choroid full thickness graft transplantation, because in this situation, the RP condition is absolutely very bad. You have to remove the CNVN part also.
Thank you.
Then replace it by the RP choroid graft. Then only you can get a very good vision. Thank you.
Thank you, Dr. Subretinal. Now I have two excellent talks remaining.